Good evening, everyone. I am presenting blog test today. My name is Dr. Pradeep Rajput. 10 years old female child, third birth order, born of non-conscious marriage, hailing from Delhi and resident of Mumbai, Ansari by community, Muslim by religion, brought by and informed by mother, which is complained of shortness of breath, pain in abdomen, chest pain, increased pulsation on right side of neck, decreased appetite. All symptoms were on and off since 2 years. Shortness of breath was more after physical activity like playing or running, making a child stop and sit for a while for relief. Pain in abdomen was periumbilical, non-localized, not associated with any aggravating or relieving factors. Chest pain was more towards right side than left side, intermittent, sometimes at rest also, lasting around 2 to 3 minutes. There was a history of pulmonary TB in the elder sibling in 2017 at the age of 9 years. History of fatigue was there, which was intermittent. History of poor appetite, history of poor weight gain is there. History of increased pulsation over right side of neck. There was no history of arthralgia or photosensitivity or malar rash. There is a significant past history. Child was not apparently all right at the age of 8 years when she had complained of fever for 1 month, abdominal pain, and decreased appetite, for which child was taken to multiple hospitals and then admitted in the peripheral BMC hospital, as symptoms were not resolved by the oral medications. It was around hospital stay was around 10 days, during which patient received IV antibiotics. Some cardiac imaging was done and further referred to the tertiary care center for senior cardiac opinion. Patient was admitted to tertiary care center for 7 days, during which some emergency cardiac procedure was done. And upon further blood and fluid investigations, patient started on oral medication for 6 months and tablet penicillin at 2 mkd for 2 months in tapering doses. After 1 month of completion of above medications, child had a complaint of periorbital puffiness, pedal edema, as well as edema all over the body, for which advice for admission. Some cardiac imaging was done and started on oral medication, which was taken for 1 year. Further, child was on follow-up for cardiac imaging in Sion Hospital and was advised for the cardiac surgical procedure. In January 2025, at the age of 10 years, after follow-up repeat cardiac imaging, PET CT scan was advised to look for the inflammatory activity in the pericardium and pericardial thickness. After which patient was referred to the higher pediatric cardiac center for surgical procedure and transferred back to the tertiary care center for further postoperative management. ANC wise uneventful, birth history wise uneventful, immunization till age, development wise appropriate for age. Dietary history wise it's from all food groups. There is history of permanent TB in sibling, elder sibling. 6 months taken. On the basis of history, 10 years old female child, third birth order, born of non-conscious marriage with history of Cox contact and significant past history of hospitalization in view of cardiac complaints with decreased appetite in a fully immunized and normal by birth and development child and thin by anthropometry. Child is the most probably case of tuberculous pericardial effusion, constrictive pericarditis, restrictive cardiomyopathy, and SLE.
Hello. Can you all hear us online?
Yes,
Rajesh.
Rajesh.
Yes, sir.
Okay, so what do you make out of this complaint? Shortness of breath, this was for how long?
It was on and off since 2 years.
Last 2 years, the complaint is there. Over 2 years, it has increased, decreased, same. Okay. What do you make out of? So whenever you have any child with shortness of breath, what are the thoughts in your mind?
Respiratory versus cardiac.
Anything else besides respiratory and cardiac? Shortness of breath is not acute, this is chronic. Okay, neuromuscular, anything else? Anemia? So now how will you differentiate all this? There are small differences. When will you call it cardiac? When will you call it respiratory? When will you call it anemia? Which one do you think? Come on.
So there would be other signs of other
Hold
signs
like this.
um, with shortness of breath if edema is also there, suggesting right-sided edema of limb with shortness of breath.
So if there is associated edema, then you will call it cardiac. What else?
Clinically, if child is pale, short, we could say it would be because of anemia.
Okay.
Breathlessness at rest or due to exertion, we will differentiate between respiratory and cardiac.
Okay. So suppose somebody is breathless due to a respiratory cause, like a interstitial lung disease. You think he won't get more breathless on exertion?
Yes, sir, but there will be breathlessness at resting position.
Very good. So there will be breathlessness at rest, which may not be there in a cardiac or a child with anemia. You were saying something?
Nocturnal awakening due to breathlessness, PND.
So that is PND. So what is PND? First, what exactly is PND?
The patient will get awake by breathlessness. He will stand behind the bed and will search for, there will be air hunger. Basically, he will breathe and then get relaxed after some time.
Why does it happen?
This is due to cooling of the blood in the.
Very good. So this is an adult phenomenon. It is seen more in adults, not in children, right? And it's a sign of left ventricular failure. Okay.
I think we need many informations about it. We can't make out with what you have given. Let's forget the past history. Let's forget off and on. Let's look at what has happened now. Now, shortness of breath, you said, at present off and on. When is it off and when is it on? Every half an hour? Every day? Every week? If you don't know, how can we further discuss the whole situation? And therefore, I think history is not his story. You gave all his story. But moment you say shortness of breath off and on, your first question would have been, when is it off and when is it on? Now suppose he said, every time on physical exercise. Then your next question is, when you are resting, you never feel short of breath. Now you start understanding the whole pathophysiology. So now let's believe that because you have said that increased on exertion or playing. But you have said more on that. Does it mean even less at rest? We have no idea. Now, unless we know all that, we will never make a thing. You have given all causes of cardiac problems in breathlessness. That's not the clinical medicine. And therefore, suppose this child, even at rest, is breathless. Okay, then how that breathless child at rest tries to play and exercise? Will he ever do that? So the whole story itself is not right. So next you should ask, but when you are breathless at rest, How do you go to play? Which possibly means that he was not breathless at rest. Now we just deduce all this, but why can we not get all this information from the parents itself? And therefore, I believe that this child was not breathless at rest because he was also trying to exercise and play. Now, what does that mean? That means that the cardiac dysfunction is just waiting to get worse, even with little exercise. Then my next question is, how much exercise? Just walk few steps or walk one stair? We have learned all this in undergraduate days. Walking one stair, walking two stairs. So degree of breathlessness. Now that would tell me that. Then further, moment you rest, within how much time you come back to taking normal breath? He would say maybe in a minute or so, which tells you that it's a cardiac problem. Now, having said that, what cardiac problem? So this is a myocardium which is just functioning adequately at rest, but with some degree of exercise, it cannot manage. So could it be myocardial disease? If it's a myocardial disease, it should be progressive over time. But that has not happened. So how can a myocardial disease will make you breathless and again all right at rest? If this keeps on happening, very soon the myocardium will fail, which has not happened. So this is not a primary myocardial disease. Could it be an endocardial disease? Endocardial disease will do the same when myocardium is involved. Not just by that. Therefore, it must be a pericardial disease. You deduce like this. If it's a pericardial disease, why is this disease causing breathlessness on rest, breathlessness on exercise, but again back to normal on rest, which means something is changing all that. What can change in the pericardium? Pericardial fluid. So there must be a pericardial fluid causing beginning of tamponade. He rests, it gets better. But then he gets treatment every time. And that's why he gets better. He doesn't get better by itself. Well, he gets better for a while, gets breathless again. But when he goes to his doctor, he gets antibiotics, steroids, whatever. Which means it's a treatable cause of a pericardial disease. That must be known. And it's a treatable cause of a pericardial fluid collection, not constrictive pericarditis. Constrictive pericarditis doesn't go up and down like this, though constrictive pericarditis, more and more constriction occurring, it could make myocardium not dilate enough or constrict enough. So pericardial disease by and large. Okay. If it's going on for 2 years, there must be element of constriction also, but there must be a filling of things also. So this is the way you start looking at it. Now you have many other clues on that. You have a pain in abdomen, which is periumbilical. What is this pain in abdomen in a cardiac disease? If you read Nelson, in a rheumatic carditis, there is a pain in abdomen. Why is the pain in abdomen in rheumatic heart disease? Any thought? And the reason is it is a vascular pain. Because the myocardium is not pushing enough blood out into the periphery, the intestinal vessels will take the first brunt to go down. The nature will prevent problems in the brain, problems in the heart, problems in the lung, thereafter the liver, kidney, but intestine will not take the first brunt because it doesn't matter. That's why pain, it's a vasogenic pain. Okay. And don't you find a typical vasogenic pain in a dang who is getting into shock? And you get pain in the abdomen when the fever is going down. That's a vasogenic pain. So this is simply a vasogenic pain. Don't give a lot of importance to it. Okay. Just confirm that it's certainly happening, etc. Periumbilical, not localized. So vague. That means intestinal. What intestinal? Without diarrhea, constipation, etc. Acute vascular. So this is a vasogenic pain. And then not aggravating, etc. Chest pains over the right. Could it be dextrocardia? Why right? We're talking about the heart disease and pain is on the right side. And that tells you that if it is not dextrocardia, then it is likely to be again a pericardium. Okay. And then better would be a retrosternal more than right or left, ideally. But that is how it is. And that's why, even with this very little details of information, we almost get to see that this is going to be a pericardial disease, recurrent pericardial disease. What is recurrent pericardial disease? Unlikely recurrent infection, unlikely tuberculosis. It'll go on worsening or it'll get better. So anything that's happening recurrently for last 2 years is likely to be immunological first. Of course, second could be partially treated, coming again and again. We'll keep all that in mind. And therefore, I think what I'm trying to kind of make a point is, even with very minimal detailed information, you should have started thinking and got more and more information. The idea is not to make a final diagnosis by hook or crook. And more than hook or crook, search for all investigation. Okay. What we emphasize on teaching here is even a crook, a doctor who has not trained, okay, can do all investigations and give a diagnosis. Okay. Any fool would have done an echo, ultrasound, whatever. So I think you need to learn how to get a history well. And therefore, even with this very brief history, you straight away get into that. Now, somewhere you have said right-sided vein. What does that mean? There is obstruction to the superior vena cava. On examination, you should find hepatomegaly, obstruction to the inferior vena cava. Again, you are getting a diagnosis of constrictive pericarditis, but not just constrictive. It is often on getting filled and causing that. Now, empyema ends with constriction, pleural adhesions. Same way, this repeated pericardial disease must be having a pericardial effusion. But the primary diagnosis is not constrictive pericarditis, right?
So this increased pulsation on the right side of the neck, do you get this history in cardiac failure also? There also JVP is raised, no? So why you don't get this history there? Your patient told you that increased pulsation, mother told. So it means it was so much that mother could observe. So why we don't get this history in cardiac failure? Just think. So in cardiac failure, there are many other prominent symptoms, and this is not so prominent. It is something which we pick up. We make them sleep in that 45 degrees, this, that, and then pick up. Whereas here it is totally obstructed, and that's why it is very prominent. So it's much more than what you would see in a cardiac failure, right? Now, quickly about the negative history. History of pulmonary TB in elder sibling. So can this be the whole thing, whole discussion is wrong? Can it be respiratory? And if it is cardiac, can it be tuberculous cardiac effusion, pericardial effusion? So two questions I'm asking. Can it be respiratory, the whole thing? That's my first question because there's history of TB. And second is, if it is cardiac, then is it tuberculosis of the heart in some way? So first question answer, can it be respiratory? No. Why no?
Because breathlessness is intermittent and improves on resting, so cardiac is more supportive.
That is one. Second,
But history of TB contact is long back.
very good. So,
Should not
how does pulmonary tuberculosis in the subject, if it were to happen, what would happen? How
first
would it
cough,
progress?
First child should have some cough and nocturnal fever.
First of all, which pulmonary tuberculosis in children causes breathlessness?
Lymph node involvement,
Lymph node where?
mediastinal lymph node.
Okay. So, why sir is asking?
Can cause compression
Hold
and
closer. Compression on what?
on the trachea, respiratory.
So that's uncommon, lymph nodes causing compression. And if they cause compression, it will not be, see, to cause breathlessness, the whole trachea or the whole major bronchus has to be compressed. That's very unlikely from external compression. So you will at the most get a irritational cough due to pressure, but not really breathlessness, right? Which other tuberculosis causes breathlessness? Okay. So endobronchial TB also, first of all, endobronchial TB is not in the main bronchus. It is further down. So the lung which is beyond that is not like one full lobe of a lung, right? So it will not cause breathlessness again. Second, miliary. So in miliary again, depending on the age and depending on the intelligence of the patient's parents, there'll be tachypnea. So they may notice that my infant is breathing faster, but that's about it. So it will not be typical breathlessness that we say, or we will see. One tuberculosis which you will see as breathlessness. Pleural effusion, tuberculous pleural effusion. So that obviously will not last 8 years, 10 years, whatever is the story, right? Okay. Now, can it be cardiac tuberculosis, so pericardial tuberculosis or whatever? So what does pericardial tuberculosis end up in? Constrictive pericarditis. So is this constrictive pericarditis? Why not? So the waxing waning course is a little something to think about, but I'm not very sure whether we can totally rule it out or it still stands. Okay. Then fatigue, poor appetite, poor weight gain, all that is there.
Think whenever the disease goes on for a long time, always ask how is the health maintained or how much is deteriorating. If this child is obviously not maintaining health, he could be deteriorating. Now, if he's deteriorating, how much is he deteriorating? And therefore, that would tell us, because this could be a partially treated bacterial infection, and every time he gets worse, he gets fever. So again, we want to know, has he had fever off and on also in between? Or it has never been with fever? Now, if it has never been with fever, then it goes in more in favor of a non-inflammatory, non-infective disorder, where I will push my constrictive pericarditis up there. But to begin with, for constrictive pericarditis develop, there had to be a pericardial disease. And at that age, pericardial disease should have a fluid in the pericardial cavity. And therefore, it's a pericardial effusion ending into constrictive pericarditis, with or without both. And that is the way it is. The whole story first started with fever. Now we will discuss only that first story, right? Just put up the first story only, forget what has happened thereafter. And let's see whether that time we could have diagnosed it as a pericardial disease. And if so, tubercle, bacterial, or inflammatory, non-infective. We could guess from there. Come on, somebody try this. Anyone who wants to try it.
Initial मध्ये he has not mentioned. So fever for 1 month at 8 years of age, abdominal pain and decreased appetite.
I was taken to multiple hospitals, which means antibiotics. Come on, start discussing the probability of that diagnosis. Come on, give a try, give a try. Senior now, yeah. That doesn't matter if you are wrong. Yeah, I could be wrong, totally. Isn't it? There is a shame in being wrong. And I must be worried more so if I am proved wrong and you are proved right. What is my image at the end of 6 decades? But I'm not ashamed because even I have not been master of everything. So talk something.
But as you said, child had fever for 1 month and as sir said, taken to multiple hospitals. So child must have received antibiotics. Also, 10 days admission is there where IV antibiotics were received till child had complaints, same complaints. So referred to higher center or cardiac was done. So would- bacterial is less likely because she did not responded to IV
No,
medication.
1 minute. See, so now what we have to learn here is forget referred to multiple hospitals, cardiac imaging, forget all that. If we only tell you that a 8-year-old has fever for 1 month, abdominal pain and loss of appetite, only this much. Now tell me, can it be pneumonia? Why not?
Some chest complaints, breathlessness should have
So
been.
there has to be breathlessness. If fever is still on by now, it would be empyema. There would be multiple complications. Can it be meningitis? So what am I saying by saying can it be pneumonia? Can it be meningitis? What you have to think is that if for 1 month this fever, the only localization it has given is some pain in abdomen, then you are moving away from so many bacterial infections. That is the point I'm trying to make, right? So most of your bacterial infections are already out at this point. Now coming to pain in abdomen, take it further. Can it still be a badly treated typhoid? Can it be a liver abscess? Think of all that and see how you can still decide whether it's a bacterial infection. It's not a bacterial infection. So think, tell me, how will you take it? Whether can it be typhoid? 1 month of fever, badly treated, some treatment here, there. Only symptom now is pain in abdomen and loss of appetite. How will you make out whether it can be typhoid or not?
History of loose stools, vomiting, along with fever if anything's there. And then hepatomegaly on examination, ultrasound, gallbladder if we see the.
Anything else? How would you diagnose typhoid on history?
Step ladder pattern of fever.
So you would go back and ask them in the first 4 or 5 days, did you get a step ladder pattern of fever? That would be a strong pointer if he was untreated in the first 4 or 5 days, whether this is a bacteremic bacterial infection, right? How would you pick up a liver abscess with this history? Okay, more than vomiting. So for any pain in the abdomen, the next question should be where is the pain in the abdomen? You start from there. Any pain in the abdomen. So you have to get the anatomy of that pain. Liver abscess is painful or not painful? Very painful. So the pain has to be in the right hypochondrium to tell you that, okay, this is a badly treated, mistreated liver abscess or whatever, right? So this is the way you think that this is unlikely to be a bacterial infection.
When you have a fever for 1 month, you have 2, 3 possibilities just by that. One is a subacute infection, like tuberculosis. And you start asking, where could tuberculosis be? Mostly pulmonary cough, etc. Or partially treated. Now, what is the importance of partially treated? He's not deteriorating. He seems to be stable, little up and down. Tubercle also would do the same for a while. So it's either a subacute infection or a partially treated infection. Or could it be a non-infective inflammation? Non-infective inflammation going for a month is very unlikely without anything else. For example, an SOGIA would have a evanescent rash, maybe something joints, which has not happened. Therefore, very likely not a non-infective inflammatory disorder. We don't rule out just by this discussion, but we put priorities. Therefore, it has to be an infection, either partially treated bacterial infection or a still untreated tuberculosis infection. Not anything else, not viral, not fungal, not parasitic. So we are dealing with a bacterial infection. Okay. Then now you have abdominal pain. Now, which abdominal pain? Typhoid we have already discussed is one type of that. No other bacterial infections have abdominal pain as a symptom. Therefore, this abdominal pain must have been a minor symptom. Okay. So forget that for a while. So let's say fever for 1 month, partially treated bacterial or subacute tubercle. But where is the infection? If it's partially treated pneumonia, there would be cough at least, if not breathlessness. If it's partially treated meningitis, there would be at least some headache, some vomiting. And therefore, this to me is occurring, infection occurring in an organ which has no other symptoms. And that's why meningitis, pneumonia, or dysentery, all are rolled out, which are silent sites where an infection does not produce any other symptom. One is the urinary tract, where if it's a pyelonephritis, nothing much to go by. If it's a lower urinary tract infection, yes, you have many symptoms like difficulty in passing, frequency, burning. But if it's an acute pyelonephritis, then maybe some back pain, maybe abdominal pain is there. But he's an 8-year-old. So why should an 8-year-old suddenly get an acute pyelonephritis? Unless there's a past history of repeated urinary tract infection. So it is unlikely urine, which is another organ where a bacterial infection or a tubercle can stay quiet, is the heart. And in the heart, the subacute endocarditis, okay, infective, HBE, subacute bacterial endocarditis, absolutely without symptoms and often without signs. And the next is pericardium. If it's HBE and partially treated, you can exactly go like this, but not with shortness of breath, etc., which has now come later. And therefore, even with that little information, we could have said, this is a bacterial infection, tubercle or non-tubercle. I'm not sure about that, but very likely connected with the heart. If it's tubercle, then it be pericardium. If it's bacterial, then possibly endocarditis, HBE are possible. So again, we could have gone probably towards the heart even with that thing. Now, can a heart disease have an abdominal pain? Yes. And that's a stretch of a liver capsule causing a little discomfort. So there must be a hepatomegaly in either of these, SBE as well as in pericardial disease.
So now let's move on to examination.
On general examination, child was active, alert, oriented to time test person, examined in lying down position, febrile. Pulse rate was 110 per minute. 110 per minute, regular good volume. Respiratory rate was 36 per minute. Saturation was 99%. BP was at lower side, 50 to 50 centile. Increased JVP pulsation were present, which was more on the right side. The patient is on O2 support board. This was on O2, 19% O2 by face mask. There was increased JVP pulsations more on the right side. Extremities warm. There was no pararectus clubbings and
Do you want any more information on JVP? In the light of what we have been discussing, do you want any more information on JVP? Because that's the only abnormality largely. When you get JVP enlarged, okay, in cardiac failure, what do you look for besides that? Come on, I'm sure you're a postgraduate, but you are not forgetting undergraduate.
JVP wave pattern.
Wave patterns. So A wave,
Pattern
C
is a
wave.
cardiologist problem, and now even they have forgotten. You are right. But something that you cannot forget as an undergraduate, hepatojugular reflex. Okay. And what type of hepatojugular reflex you expect in this child with our discussion?
First, tell us what do you remember or understand of hepatojugular reflux?
He's giving you option, understand or remember.
Come on. Please, mic. Hold the mic and speak in the mic. Come on, we are all learning. So good to speak, that's all. Whether right or wrong doesn't matter. Hold it close.
Sir, we actually sir, while palpating liver, we uh, uh, we see JVP rise in JVP when palpating liver, sir, or compressing liver.
Very good. What does that mean? You're right. The first part is perfect. Now take it further.
Usually with compression of lever, JVP rises. If it doesn't fall, then that suggests right-sided pain.
If it doesn't fall, then
Usually it rises and falls.
very good.
But if it doesn't fall or fall after,
No, obstruction we are coming to later. Good. Very good. So when you compress on the right hypochondrium, you are pushing a lot of blood from the hepatic circulation into the IVC and then into the right atrium. So right atrium, which is normal, there will be a little rise in JVP, but immediately the right atrium adjusts to this increased volume and that JVP will come down. So that is normal. But when there is cardiac failure, that right atrium cannot adjust to this increased volume. So that pushed JVP will be sustained. So this is called hepatojugular reflux positive, which means that the patient's right atrial compliance is not good. Clear? This is normal. Now, sir is asking what would you expect here? We have discussed something. What are we discussing? Remember that. And we just discussed the physiology. Connect the two and tell us what you expect here.
we are suspecting pericardial effusion and not constrictive pericarditis. So JVP should fall after some time.
And if it is constrictive pericarditis,
Then the reflex would be positive. Sustained JVP rise.
any other thoughts? Why is the vein so prominent? We have discussed much more than cardiac failure. We said in cardiac failure, nobody gives us this history that this vein is prominent. So if there is obstruction, what will happen to that physiology that we discussed? We discussed some physiology 5 minutes back. If there is obstruction, what will happen? If there is obstruction, when you press, that extra blood will not be transmitted only, no? So that initial push, which is normal, also will not happen. Nothing will happen. So that is known as hepatojugular reflux absent. That tells you that there is probably a block somewhere.
We said sustained is abnormal. This is not sustained. So absent. Okay, so normal is also absent. And obstruction is also absent. So how do you differentiate that? Okay, I'm asking a silly question. Okay. How can a normal fellow will have distended veins? No, why are you discussing that? Okay, so no question at all. Can plantar reflex be absent? I know, flexor or extensor, no? Can it be absent? Funny, no? How can it be either flexor or extensor? But can it be absent? Come on, give a thought.
Yeah? Yeah, so why? Why do you get absent?
The motor neuron itself is not functioning, then the muscle won't move.
So one is if the muscle is paralyzed, it won't move. So zero power won't move. Second,
Signal is not transmitted.
so no afferent. So sensory loss, it won't move.
One important clue to the pericardial diagnosis is when you have seen such a big pulsations, even the patient can make out, there has to be a proportionate tachycardia. If the pulsations are so high, you're not mentioned about tachycardia here, but if there is constrictive pericarditis, the pulsation, the prominent of the JVP is out of proportionate to the tachycardia. You may have a very prominent JVP, you may expect the child to be in mark failure. Heart rate 140, 130, his heart rate maybe 101, 102. So this is disproportionate. So the tachycardia is disproportionately low for that JVP, which even the patient's relative can. So this JVP is probably not related to cardiac thing, but it is as a result of obstruction, constrictive pericarditis. Also, please remember, constrictive pericarditis does not mean the entire pericardium is constricted. It may be constricted in patches. There can be a greater constriction here, or there can be a greater constriction here. Entire heart is not constricted. One thing I always wanted to think here, if I have to come to a pericardial disease, for whatever little cases we have seen, chest pain is very important. You can't have, means there are so many types of chest pains, but chest pain, significant chest pain, midline chest pain, and breathlessness. Take any other cardiac condition. Respiratory diseases don't have central chest pain at all. Okay, chest pain and fever, though uncommon, should come to pericardial. And whatever little pericardial we have seen, they are significant pain. If it is pyopericardium, they are literally bending like this because of. And if it is pericardial disease not due to that, then chest pain, because pericardium is the only organ around the heart or of the heart which has pain sensation like the pleura. So I thought there should have been the chest pain complaint prominent rather than the abdominal pain, which was absent here.
Why there is a bradycardia? 30.
No, sir, actually it's a mistake. 110 was there. Pulse rate was 100. It
I was
110.
worried. I said,
Writing mistake. Anthropomedically, weight was 22 kg, which was around -3 to -2 standard deviation. Height was 129 centimeter, which was around -2 to -3 to -2 deviation. And BMI was 13.2, which also -3 to -2 standard deviation. And impression wise, thin on head to toe examination. There was a site of a central line removed badge was there. Thoracotomy sutures in place of in the place of the chest, in midline sternum side. Rest head to toe examination was normal. On system examination, CVS wise on inspection, operative sutures with dressing in situ was there. There was no precordial bulge. On palpation, tenderness present over sternal borders. On percussion, dull note was present all over cardiac region. On auscultation, there are no murmur. S1 S2 heard, and there are muffled heart sounds. On respiratory examination, air intake was decreased on left side. There were mild crepitations on auscultation on the more on the right side, right side than the left side. Per abdomen was soft, non-tender. Liver was 2 centimeter. Spleen not palpable. CNS wise, tone, power, reflexes, tone were normal in all 4 leaves. Power was greater than 3.5 in all 4 leaves. Reflexes were 2 plus. On the basis of history and examination, a 10-year-old female child, third birth order, born of non-conscious marriage with history of Cox contact and significant past history of hospitalization in view of cardiac complaints with decreased appetite in a fully immunized with normal by birth and development child and thin by anthropometry. With examination findings of increased JVP pulsations over right side, BP slightly on the lower side, muffled heart sounds. This is most probably a case of tuberculous constrictive pericarditis or tuberculous pericardial effusion.
In the exam, if you are asked what is the clinical sign to suggest pericardial effusion, what will you say? Muffled heart sounds can be in myocarditis. So in percussion, what are you supposed to get? Pericardial knock is different. So normally when you do cardiac percussion, what is your sentence when you're talking to the examiner? The heart borders, dash with the dash. Excellent. So in pericardial effusion, what will be your sentence? So the left heart border does not correspond to the apex. That is the clinical sign of a pericardial effusion.
Put together constrictive pericarditis and effusion. One does not know, but if the chronic process probably is, it's not the entire pericardium which will go in constriction simultaneously. There may be areas where the pathology is little advanced than other, and there can be patches where the constriction is more and where there can be some effusion still there pending. And if that constriction is involving the upper part, then the JVP is more common. If that involves the lower part, then the symptoms related to tender hepatomegaly will be found. This is my guess, sir. What do you think?
Uh, Patient was admitted in the Sion Hospital 2 years ago. When by Patient was transferred to peripheral BBC hospital and admitted in the peripheral BBC hospital for 10 days. But despite of IV medication not relieved, then patient was referred for the further cardiac opinion to the Sion Hospital. In Sion Hospital, cardiac opinion was taken and the patient was done with pericardial synthesis on 8th of September 23 in view of severe pericardial effusion, which was diagnosed on 2D echo. And fluid was sent for the analysis, which was fluid RM was suggestive of TLC count of 210, and it was a lymphopredominant with increased protein. And biochemical analysis was suggestive of increased AD and LDH. Patient Cox workup was done. Montus test was positive and ESR was 115. It was raised. AKT was started on clinical and above investigations. Started on 11 September 2023 and completed on 6th March of 2024. That is for 6 months. And the patient also received tablet prednisolone for at 2 FKD for 2 months, which was gradually tapered and stopped in next 1 month. After 1 month, on 3rd of April 2024, child came in CCF. X-ray was done, which was showing the mild cardiomegaly with mediastinal widening, and there was pericardial effusion. Signs of pericardial effusion was there. Then 2D echo was done, which was suggestive of constructive physiology and moderate MR. The patient started on the tablet lasleptin in view of CCF, and which was taken for that 1 year. Child was on follow-up with 2D echo at Sion Hospital and advised surgery for constructive pericarditis. In January 2025, advised PET scan post 2D echo to look for the inflammatory activity in the pericardium and for pericardial thickness. The PET CT was done, which was suggestive of active infective or inflammatory process involving the pericardium. CT chest also was done, which is suggestive of concentric pericardial thickening up to 6 millimeter with loculated pericardial collection as described in the anterior aspect of the both ventricles, more on the right side, and dilated hepatic veins as well as the superior vena cava and pulmonary veins, and mildly dilated MP and LPA. There was no obvious lung parenchymal disease. Child was referred to the Sri Satyasai Hospital for further surgical management, where pericardectomy was done on 16th of April 2025, and operative findings were constrictive pericarditis. The pericardium was thickened, adherent overall structures of cardia. There was dense adhesions over the left atrium, left ventricle, and anterior aspect of the right ventricle with calcification. Approximately 8 by 6 centimeter dense lobulated local collection of purulent material over the left ventricle apex and the lateral wall was there, and dilated IVC was also noted. Intraoperative findings showed the pustular pockets on the pericardium, which is cages necrosis, which was removed and the tissue and first sent for the analysis. The pulse gene expert MTB, XDR, and RIF ultra further showed resistance to INH and low resistance to fluoroquinolone, and also rifampicin. So patient was diagnosed as MDR TB. AKT is being mobilized for the child post evaluation. These are the recent blood investigation of the patient. Currently, child is admitted in the ward on IV fluid and IV antibiotics and post-op care. MDR TB is being mobilized for the patient. Patient is currently on the O2 support with biomass. Thank you.
Fine, thank you. Any questions? Any questions from the online viewers? Okay. So we'll move on to the second case for today. Yeah.
One month, 20 days old female child, first by birth order, born out of non-consanguineous marriage, resident of Dombivali, hailing from Savantwadi, Hindu by religion, Maratha by community, brought by mother with complaints of yellowish discoloration of eyes and skin since 3 days. Patient was apparently all right 3 days ago, after which mother noticed yellowish discoloration of eyes and skin of whole body. There was no history of yellowish discoloration of urine or staining of diapers, no history of pale colored stools, no history of abdominal distension or swelling of whole body, no history of bleeding from any side, no history of
Rajesh, we have the old presentation. New presentation can't be seen.
RG, refusal to feeds and irritability, no history of seizures, altered sensorium, hypotonia, no history of oliguria or crying while micturition, no complaints of decreased oral intake, passing urine and stools adequately. There is no significant history of any admissions in the past. ANC history, registered and immunized. ANC scans were normal. History of gestational hypertension in mother since 7 months of pregnancy on antihypertensive medication. No history of hypothyroidism, diabetes, jaundice, pruritus, fever, rash, arthralgia in mother during pregnancy. No history of any foul smelling liquor or draining per vagina. Birth history, very preterm, LSCS, in view of fetal distress, PIH, baby cried immediately after birth, birth weight of 1.6 kg, history of NICU stay in view of low birth weight for 8 days, no history of any respiratory distress requiring O2 support, no history of any birth trauma, no history of delayed passage of meconium or urine, breastfed on day of life 3, first 2 days exclusively breastfed via Vati spoon feed. History of neonatal jaundice on day of life 4, received phototherapy, discharge on day of life 8. No history of any total parental nutrition, exchange transfusion, sepsis workup was normal. Child was birth vaccines given, developmentally sucking and rooting reflex present, startle reflex present, palmar grasp was present, fixation and follows to light. No family history of jaundice, gallstones, cholecystectomy or blood transfusion in the family. Child is on exclusive breastfeeding. Family belongs to lower middle class 3 by modified Swami scale.
Wait. So you said 1 month, 3 days old. And jaundice noticed since 3 days. And urine not high colored. And that time, at the time of birth, there was jaundice.
Mother told that there was jaundice on day of life 4. He was kept in in phototherapy for 1 to 2 days, and after that he was discharged from there.
So that jaundice had disappeared.
Disappeared. Actually, the mother also not noticed that. He was told uh, by his mother कि the child is looking very matlab, there is yellowish discoloration of body. Then he came to know. Matlab, mother did not notice actually. हाँ, one 1 month 20 days.
So what do you all think? History seems to say that this is a unconjugated or indirect jaundice in a 1 month, 20-day-old baby, which has come back after the normal physiological jaundice. What could be the reasons at this age?
Simple breastfed baby. So breastfed baby is jaundice.
So is this feeding jaundice or breast milk jaundice, or both are the same, or this is neither? Many questions now. Start answering. So breastfeeding jaundice and breast milk jaundice, they are same. So what is the difference?
Breastfeeding jaundice is due to insufficient breastfeeding, and breast milk jaundice is due to some molecule in the breast milk that causes unconjugation of the bilirubin.
Which one is this? Neither. So what are the possibilities here?
Syndromic,
Like which syndrome?
regular Najar,
Okay, so enzyme deficiencies. So either indirect enzyme deficiencies which cause indirect bilirubin like Krigler-Najjar or Gilbert. Anything else? Can it be any hemolytic anemia?
This is very early for any hemolytic anemia.
Agreed, it is very early. But in case it is, then which one, and then what will you look for and all that? So hereditary spherocytosis, what will you look for? Clinically, pehle. Hepatospleno. So Karisar has given a clue, examine the parents for spleen, but pallor in the baby, no? So you have to look for pallor in the baby, because if you have a recent onset jaundice, that means current hemolysis is going on. So then there should be significant pallor. Anything else? Other causes of indirect jaundice in a 1.5-month-old baby.
CMV.
So you're meaning congenital infections. So congenital infections, again, discuss for and against, and what will be there in addition to this. So most infections will cause conjugated jaundice, not just unconjugated. And if it's a congenital infection, then failure to thrive, low birth weight, which is there. And then you have to look for other things like hepatosplenomegaly or other system affection. So that we will find out on examination. Anything else?
I think that statement that eyes and skin both are yellow is almost not possible. The skin gets yellow only when bilirubin is very high. And therefore, if this is very high bilirubin, why did it develop in last 3 days? So there is something wrong in that statement. Okay, you almost never see a patient who says, my skin is yellow. The skin is yellow at the far end of worsening bilirubinemia. So first we need to check whether that statement is right. The mother may have said it,
But for you, it's not possible. Therefore, either we take that both are yellow, which means that yellowness is very severe, and therefore it must have started pretty early, which means very almost at birth. So that is the probable understanding out of this. Both skin and eyes are yellow. If it started early and it's very severe, then it's an indirect bilirubin, but it's the non-hemolytic indirect bilirubin apparently. Okay, because pallor is not there. So which are non-hemolytic indirect bilirubinemia, which are severe, and whether this is a Crigler-Najjar type 2. Okay, which has started worsening after a week or so, and by the time it has got worse after a week, the blood-brain barrier is already mature, and therefore it has not hit the part of the brain, and therefore we don't have any obvious CNS complications of a Crigler-Najjar type 1. So type 2 will come up a little slowly and increase. And I recall having seen a mother who was absolutely yellow because of Crigler-Najjar type 2. And she came to ask me whether she could transmit this to her baby. That was her worry. But wherever she went in the population, they said, Acha doctor ko batao. And she was healthy and fine. So the question is, are you dealing with a Crigler-Najjar type 2? Okay. I'll give you another example of a possibility. You know ABO incompatibility. You know RH incompatibility. When both are present in a situation, how does the jaundice proceed? Is it double or 1 plus 1 is less than 1? Some thought. Some thought. When there is a double incompatibility, each compatibility will destroy the other. So the double incompatibility may be in favor of not very severe problem. So is this a double one? If it's a double one, what do you want to ask the mother first? Is this the first baby? It's not first baby. It's the first baby. So you don't know. Okay. So, yeah. No. So keep in mind a double incompatibility. Okay. Or a Crigler-Najjar, or the skin itself is not yellow. And then it's a probably breastfeeding jaundice should have been noticed earlier. Could it be hypothyroid? Mild jaundice picked up later by the mother. Okay, and you have just 1 month, 20 days. So difficult to pick up some delay occurring. Again, that jaundice should have been, when do you expect all this? A persistence of physiological jaundice beyond expectation. All these conditions. So possibly not, right? So before he gives the finding, would examination solve our problem? Let's guess. Doesn't matter. What we have said, if both are so yellow, could it be Crigler-Najjar type 2? Then what do you expect on clinical examination? We said double incompatibility. If so, what do you expect on clinical examination? So give a thought and just try that. I think this is the better way of learning medicine. Nobody's going to ask such foolish questions to you. Okay, they will give you MD before they ask you this question, but in practice, somebody will ask you this question. Come on, give a thought. I know you can talk.
So Crigler-Najjar type 2, which clinical finding confirms the diagnosis?
Hepatomegaly.
There's no clinical finding. So you don't get any findings. So you will look for a growth of the baby which is compatible for the age considering the birth weight, telling you that all is otherwise normal. What about double incompatibility? ABO and RH. Organomegaly, okay, maybe hepatosplenomegaly, but what else? Which is almost important, sure. Pallor. Now again, 6 weeks, 1 month, 20 days. Normal baby is pale or not pale at 6 weeks? Physiological anemia is there, but it's not so strikingly pale. It is just that you expect physiological anemia, right? So if this baby is looking obviously pale clinically, then it probably more than physiological anemia, right? Okay.
Would you like to look at the mother? Is she likely to be jaundice if she's Krigler-Najjar type 2? What is the inherent? Dominant or recessive? Huh? If it is recessive, she may not be jaundiced.
On examination, child alert, active, afebrile, heart rate of 146 per minute, respiratory rate of 150 per minute, and saturation 99%, peripheral pulses well fed, extremities warm, CRT of less than 3 seconds, head to toe examination, AF at level, open 4 into 5 centimeter, PF open 1 by 2 centimeter. If tears present, no petechia, purpura or rash, head and neck normal, hair normal, no signs of vitamin deficiency, no cataract, no facial dysmorphism, oral cavity normal, BCG scar present, no umbilical hernia, spines and genitals normal. Sir, anthropometrically, child is normal as per the age plotted on the Fenton's chart. Corrected gestational age was 37.7 weeks. So the head circumference was between 50th to 90th centile. Length was between 10 to 50th centile, and weight was between 50th to 90th centile. So he was appropriate for the age. Systemic examination per
You
abdomen.
don't have the actual readings.
I forgot.
You have it on your.
Weight 3 kgs, length 46 centimeter, and head circumference 35.
Length 42.
Length 46 centimeter.
46.
Yes, very preterm child.
Gestational age was
30.6. On systemic examination, per abdomen inspection, normal shape of abdomen, no dilated veins, scars, centrally placed umbilicus, no plankfulness, palpation, liver was palpable 1 to 2 centimeter below the right subcostal margin, firm with rounded margins, spleen 2 centimeter, palpable, firm below left subcostal margin, percussion, no shifting dullness, auscultation, bowel sound present, respiratory system, air entry bilaterally equal, no adventitious sound, previous S1, S2 normal, no murmur, CNS, cry tone and activity was normal. Impression, 1 month, 20 days, female child, case of neonatal jaundice under evaluation to rule out hemolytic anemias, hereditary spherocytosis, G6PD, AIHA, hypothyroidism, and familial disorders of bilirubin metabolism like Krigler-Najjar.
is your comment on 4 by 5 centimeters anterior fontanelle at 1 month, 20 days? That was 4 by 5 centimeters. You didn't mention whether skin was yellow. We are wanting to see whether skin was also yellow. You said eyes were yellow, but skin was also yellow. What does that 4 by 5 at 1 month, 20 days? Is it a normal size anterior fontanelle or it's wide? So there must be hydrocephalus. And that hydrocephalus is due to some obstruction to CSF circulation. So there must be some hematoma somewhere. And okay, that hematoma is causing jaundice, indirect bilirubin. So you got a diagnosis. Okay, hematoma, hydrocephalus, indirect bilirubin. Okay, and only last 3 days. Is this right? Give a thought, give a thought. Okay. So what should that hematoma somewhere intracranially, wherever you want, how should it present? Of course, it's simple.
Conversion.
Convulsion. Okay.
I just want you to remember that a large hematoma can cause jaundice. That was all, yes. That was all my reason to bring in that. That's out of question. But now why 4 by 5? It's too big.
So causes of large AF, malnutrition. So this baby is malnourished, no? Preterm, low birth weight. Huh? Hypothyroidism. So this baby is not malnourished, 1.8 and now 3 kg. So this weight is pretty good. So hypothyroidism you want to keep in mind now. Tell us other things, other features to look for hypothyroidism. Okay, constipation, then
Say delayed passage of meconium. Okay, you're right. What you mean by that? Yes.
so if this baby is manifesting hypothyroidism clinically at such an early age, what happens in the immediate neonatal period?
Sleeping. Okay, I recall a neonate who came with refusal of feed right from birth. And what is refusal of bed for a neonatologist? Sepsis, rule out, send for all septic screen, start 2 antibiotics. This happened on Saturday. On Monday, when I went round at JJ, they said all tests are normal. So what could it be? Okay. They said, how is the baby? No, baby is same. This was euthyrosis. No thyroid at all. And what was not looked at it, the heart rate was 40 in a newborn. We diagnosed sepsis and septic screen without noting heart rate. Actual situation. I'm sure who you just see he's alive, no, heart must be beating next. So hypothyroid can cause bradycardia, of course, that was euthyrosis. And I remember once an endocrinologist had come, earlier we used to call endocrinologist also. They said you can palpate thyroid, and if you cannot, on palpation, thyroid is not seen, it's the thyrosis. Okay, no, you can't palpate the thyroid. For us, it's impossible. But this girl had said,
Nalin.
yeah, Nalini. Nalini was doing one of the things. And I remember, sir, you can palpate the thyroid, but this baby has no thyroid. No, that's an endocrinologist.
Yeah, Downs. Yeah.
And if I think 4 by 5 centimeters was fontanelle, which is rather too big. When is the fontanelle the maximum? At birth or sometime later in life? And why? maximum open fontanelle is around 4 months or so, because the head is enlarging at a bigger size, 2 centimeters per month. So in 3 months, it has increased by 6 centimeters. But the inward growth to close the fontanelle of that is not matching that. So that is normal. And if you have pathological big fontanelle, it should be bulging. This particular child had a normal fontanelle. Now, out of in the history, there is a one sentence which, if is concealed, the differential diagnosis, which is that sentence in the history. You don't mention that sentence and the deed right. Eye colored urine or former colored. It separates the two, and the differential diagnosis becomes very narrow from. So a simple looking thing like color of urine, so important.
Outside investigation. SGPT 30.4, total bilirubin 14.3, direct bilirubin of 3.2, indirect bilirubin of 11.17, CBC hemoglobin of 9.1, 27.9, and platelet count of 3,16,000. PT-INR was PT18 and INR 1.5. Baby blood group was B positive. Mother blood group was also B positive. Here we sent CBC, WBC count of 8,000, hemoglobin 11.7 grams, hematocrit of 33.3, platelet 2,77,000. GGT was sent, which was 147. On PS, there was presence of macrocytes, normocytes, hypochromia. Retic count was 4.7%. Corrected retic count was 2.7%. Total bilirubin was 10. Direct bilirubin was 1.8. OTPT was 24 and 12, and ALP was 634. Serum calcium 11 and phosphorus 7. G6PD levels were sent, that was 10.8 microgram per HB. Chest X-ray also. This was the picture of the patient was discharged actually. So I brought the picture of the patient. Discharged 2 days back.
Discharged. So what's your final diagnosis?
Sir, actually the enzyme studies and membrane studies of this baby has been sent to NIH and the report is awaiting.
So you're thinking of hemolytic anemia.
Thyroid profile of the baby was also sent, that was normal.
Third, 14 or 13 with 3.2 direct. See, what is the significance of this bilirubin? 14 and then 3.2 direct. What does it mean to you? First of all, is it indirect bilirubinemia, direct bilirubinemia? What is it? So more than 20% of total. So this is direct, right? So therefore, that whole concept that this was indirect is gone after measuring. And there must be high colored urine, but parents have not seen, right? So this is conjugated jaundice. The moment that comes in, your hemolytic is out. Hemolytic has to be pure indirect bilirubin, right? So that is one. Now, what else can it be? So liver enzymes, he said, are normal, and GGT was 140 something. GGT is 140. What's the normal limit of GGT?
0 to 55.
So slightly raised GGT. So little bit of cholestasis, you can say.
You have done a routine urine examination? Or bile?
Should have done. OTPT is normal, no? SGOT, SGPT.
Four and 12.
24 and 12, SGOT, SGPT. Yeah, ALP is high and this is high. GGT is high. So some cholestasis is there. So, sir, PFIC is a possibility. Yeah. Yeah. So basically, first you have to pick up cholestasis. So first you have to move from indirect to say that this is looking like there is direct. So therefore there is cholestasis. This is not your usual extrahepatic biliary atresia, etc., etc. So there is cholestasis. So it could be even intrahepatic cholestasis. And then you think of inborn errors. So PFIC is one variety of intrahepatic where there are in genetic defects. Not all PFICs have a low or normal GGT. There are 3, 4 types. So only some have low or normal GGT, others could have high GGT. So you'll have to see whether this child keeps worsening, right? And for spherocytosis, that spleen, etc. Again, in a newborn, spleen can be normal also. So that's not necessarily abnormal. Did you examine the parents as we were saying?
Mother was not having splenomegaly.
Not having splenomegaly.
For a PFIC, etc., indirect bilirubin looks pretty. It should have been a total direct bilirubin. And GTT could be normal also in one type of a PFIC, but otherwise it should have been much more direct, very little indirect. So here, indirect is more, in a direct bilirubin, which suggests that it's a primary hepatocyte disease, which is probably non-cholestatic. And that small rise in GTT could be just normal at that age. And therefore, I feel we must look at a primary hepatocyte disease and call it a neonatal hepatitis, more likely than cholestatic joint. But I think we are just guessing what it is.
So you
Little less likely. If it was a little young baby, one would have considered even malaria. In the absence of fever, presenting only as jaundice, but no pallor. No pallor.
Genital malaria doesn't cause jaundice. It causes only severe pallor. And no malaria causes jaundice unless there is a malarial hepatopathy. So in malaria, jaundice and pallor don't go together. Right?
okay, so let us know next time. You said retic is slightly high, you said, no?
Corrected retic was 4.1% and corrected retic 0.7%.
Okay. Fine. So we'll wait for an answer. What this turns out to be will probably be updated next time. Any of you have any of the feedbacks of earlier cases? Last time that neuro case which was presented to Udani sir, how is that child?
NMD and MOG levels were negative. NMD and MOG levels were normal, sir. And the child was started on methylprednisolone, and the movements were decreased and child improved.
So he has improved on methylprednisolone, but NMDR and MOG is negative. So it could fit into what Udani sir was saying as antibody negative autoimmune encephalitis. Okay. Anjali, I think Pallavi can unmute you.
Yeah, I've unmuted. I just wanted to ask whether this child looked dysmorphic and whether allergy or something is a possibility. Can we see the picture of that child?
Hello.
Yeah, Rajesh. Can you hear?
Rajesh sir, ma'am is asking to show the picture. Can you show that picture?
Sorry, we can't hear you all clearly. Anjali, you'll have to type in the chat box. So the clinical picture is just showing a baby, not showing any specific findings. Did the child look dysmorphic, you are saying? No. Okay, fine. I think we'll stop here. Thank you everyone online for joining in. We meet next Thursday again at 6 p.m. Thank you. Thank you.